part 5 of bowel elimination and GI dysfunction. So, short bowel syndrome. At Valley Children's, you'll hear people call it short gut syndrome. Same thing. This is having not enough intestine, and typically we're talking about small intestine here. So you don't have enough intestine to absorb all the nutrients you need. So it's a malabsorptive disorder. You're also going to have increased fluid and electrolyte losses because these kids have chronic diarrhea. So what causes this? Well, occasionally congenital anomalies, often NEC, necrotizing enterocolitis, that happens with our preterm babies, the volvulus that we talked about just a little while ago where it twists around and pinches off the blood supply, or trauma that damages the intestine, but something happens and the intestine has to be taken out, and now you're left with not enough intestine to live on. So these kids are TPN dependent, parenteral nutrition. They go home on it. We train the families, if you have TPN that is so hypertonic, you have to have a central line. So we're teaching families how to manage a IV pump, how to care for a central line, how to watch for infection, because that's our big problem with these kids as they come back in with central line infections. We do want them to get as many calories as possible through the gut, so we usually also put in a gastrostomy tube and do continuous feeding. So we maximize what they're absorbing through the gut, not just a few meals a day, but continuously, and things that are in a form that's easier to absorb than having to break down food. We let them eat too, because one of the big problems with having a gastrostomy tube, if you never eat, you start to dislike taste and flavor and textures in your mouth. And once a child becomes orally defensive, where they don't want anything in their mouth, that is nearly impossible to break. So we usually do try and keep some flavors, some textures going into their mouth. Some of these kids, as they grow and develop new tissue, they'll be able to get off of the TPN. Some of them have to get a transplant before they can get off of it. And TPN is really hard on your liver. So they're always a balancing act where we push the TPN, then their liver enzymes start looking back. So we back off on it, but then we start seeing their growth fall off the growth curve. So we start pushing the TPN again, and then we have to back off. So they're complicated kids, but great kids. They tend to be developmentally totally normal, except they have all these medical equipment that they need. Celiac disease. This is your gluten intolerance. It's an immunologic disorder reacting to gluten. So this is more of an allergy than just an intolerance. This is not just I don't break it down and it makes me feel bad. It does damage to the tissue, the villi in your gut, if you're eating gluten and you have celiac disease. This does not get better. It does not go away. People who are lactose intolerant, it tends to flare up and get better at different times in their life. This doesn't. So you're going to see characteristics, the steraturia, which is your big fatty stools, because you're not breaking it down. Malnutrition, just sort of general malnutrition, because they're not absorbing well, and you irritate all that gut, so they don't absorb even the things they can. They tend to have abdominal distension and nutritional deficiencies. Again, you irritate everything, so what they should be able to absorb, they can't, just because of the irritation from the gluten. So here's a list of what you can and can't eat with celiac disease. The I'm hopping over to the avoid. The big problem is wheat and similar grains. So it's wheat, rye, barley, oats. Anything with that you can't have. Instead, you can use rice flour or soy flour, potato starch, corn or potato starches. They've got to be super careful though of reading all labels, because a lot of stuff has additives, and even a small amount of gluten will cause some irritation. I have heard of people with celiac disease needing blood transfusions because that irritation in the gut, they just have this small amount of occult blood in the stool to the point that they end up needing a blood transfusion as they're trying to diagnose this. So they need to be very careful and very compliant with their diet. So let's talk about now liver and biliary problems, hepatobiliary disorders. So first one, pancreatitis. This is an inflammation of the pancreas. Usually it's caused by either trauma hitting and damaging the pancreas, alcohol or drugs. That's not usually our cause with kids. Multi-system illnesses, and this seems to be the one that we see quite often. They have something else like inflammatory bowel disease or lupus, and that irritation flares up in the pancreas as well. Can happen just from a viral illness that settles in the pancreas, or they can be born with a structural anomaly. What we're watching is their labs, particularly amylase and lipase. During a pancreatitis episode, we need them to be NPO. That we don't want the pancreas having to make and release the pancreatic enzymes. So NPO, which usually means at least IV fluids, but usually TPN, total parenteral nutrition, while they're NPO. It is painful. We've got to manage their pain. We only let them start eating orally after that amylase is back to normal. So while we're giving TPN, we may, if their stomach's full of stomach juices, we may need them on an NG to low continuous suction, getting that out. Biliary Atresia. Remember, atresia means it's not there or it does not function at all. So this is absence of functioning biliary ducts. So bile does not get out. So we get basically cholecystasis and end-stage liver cirrhosis. The bile stays in there, ends up auto-digesting the liver. So this is a child who gets jaundice about 2 to 3 weeks of age. And that jaundice, you end up with pale stool because you're not putting bile into, it doesn't go through the GI system and come out in the stool. And instead you're having to get rid of the normal bilirubin breakdown that you have in the urine. So you get dark urine, pale stools. So this requires surgery. The earlier surgery is done, the better the results. Before 45 days has better results. And even with that, a lot of those kids will end up over time needing a liver transplant. So the procedure is called a Kasai procedure. And what they do is take the intestine, right? Here's your stomach, here's the liver, and here's the intestine coming down. They cut it right here. And the other end that they cut, they took up here and attached it to the liver as if it were the bile duct. And then they took where they cut and put it down here. So this end and this end used to connect. And instead now this is like a artificial bile duct, and here's your small intestine that dumps in here and continues on. So we get some of the bile with the different enzymes going in there and not staying in the liver and doing that damage to the liver. So this This is something, though, that is difficult to manage, and even with the best treatment, they will probably need a liver transplant within a few years.